We are live now, doctor. You can start the session.
Good evening, everyone, and a warm welcome to this special Journal Club session. And on behalf of all the office bearers of the Glaucoma Society, I am very glad to invite you all to join this and enjoy the session today. Today, we have Dr. Ishwarya Anandita, who is a fellow at the Satyan Eye Care Center in Coimbatore, and she is going to present to us an article which is of great importance because it is the 20 years follow up of the ocular hypertension treatment study, and she is going to talk about the cumulative incidence and severity of POAG in this cohort. So, and we have Dr. Mani Bhaskaran from Sankar Netralaya, Chennai, who is going to be the moderator and discussant for this paper. So I would invite Dr. Aishwarya to start with her presentation.
Yes, sir. Sir, is my screen visible, sir?
Yes, it is visible. Yes.
Yes. Thank you, sir. Good evening, everyone. I would like to thank GSI and Dr. Satyan, sir, for this opportunity. Today, for the Journal Club, we'll be discussing on the ocular hypertension treatment study, phase 3. Which is the assessment of cumulative incidence of severity or of the POAG. Assessment of cumulative incidence and severity of POAG among participants in the ocular hypertension treatment study after 20 years of follow-up. This was published by Kaz et al. In JAMA Ophthalmology in April 2021. Before we go into this phase 3 study, let's have an overview of the ocular hypertension treatment study, all three phases. First phase was conducted between 1994 and 2002, where they followed up the patients for 5 years duration and then keep the phase 2 study. This phase 2 study was done between 2002 to 2008. And then the current phase 3 study was done between 2016 to 2019, studying the 20-year follow-up of these patients. So first is the ocular hypertension treatment study, phase 1. In this study, it was a randomized control study. The recruitment was happening between 1994 to 1996, and then they followed up the patients for the period of 5 years. So they selected patients such that their IOP was more than 24 and less than 32 with a normal visual field and a normal optic disc examination. A total of 1,636 patients were recruited and they were randomized into two groups, the medication group containing 819 patients and the observation group which contained 817 patients. And the medication group received treatment such that their IOP came to the level of less than 24 with a minimum of 20% reduction in the IOP, but not less than 18 mmHg of mercury. And then these patients were followed up 6 monthly. At 6 monthly follow-up, visual field analysis was done and IOP measurement was also done. And an annual disc examination and photograph was done for these patients. And they looked for if there was any reproducible visual field defect and or optic nerve head deterioration in these patients. What they found in this study was the cumulative 5-year probability of developing POAG was actually significantly lower in the medication group when compared to that of the observation group, which was 9.5% in the observation group and 4.4% incidence in the medication group. And this OHDS phase 1 study also gave an multivariate prediction model. This prediction model helped to categorize the patients into low risk, moderate risk, and high risk of developing POAG. And this prediction model was actually approved by the European Glaucoma Prevention Study also. Next came the ocular hypertension treatment study, phase 2. So this phase 2 study was done from 2002 to 2008, and they followed up these patients for a period of 13 years. So what they intended to find in this phase 2 study was whether delay in treatment had any deteriorating effect in patients who were in the observation group. So out of the initial 1636 patients, 1366 patients participated in the phase 2 study. And what they did in this study was they treated both the groups, both the medication group and the observation group were treated in this study. And the same treatment protocol and follow-up protocol was followed in phase 2 study as in the phase 1 also. And they looked for the efficacy of whether earlier treatment or the later treatment helped in preventing POAG in ocular hypertension patients. So the medication group had actually been receiving medication for 13 years, whereas the observation group patients were observed for 7.5 years, and then the treatment was initiated for the last 5.5 years. So what they found was the incidence of POAG in the observation group was actually equivalent to that of the medication group. And they concluded that individuals at high risk of developing POAG can actually benefit from early preventive treatment compared to the other group of the individuals. Moving on to the ocular hypertension treatment study phase 3, which we'll be discussing today. So the objective of this study was to identify the 20-year incidence and severity of primary open-angle glaucoma in ocular hypertension patients, and also give a prediction model for stratifying the ocular hypertension patients by their risk for developing POAG. So this study, phase 1, started with 1,636 patients, but out of those 1,636, phase 3 were able to only assess 971 patients. And these 971 patients also, only 661 patients were able to attend the examination of the ocular hypertension treatment study phase 3. 85 patients, only their medical records and clinical data were accessible. So those data were taken for study. And 225 patients had actually died, but they had attended one of the phase 1 or phase 2 examination within 2 years of death. So their clinical data while they attended the phase 1 and phase 2 had also been taken into the study for reports. So this was a long-term cohort study of the RCT, which was conducted across 22 centers, and the patients were followed up for 20 years or until the death of the patient. And the POAG endpoint was defined such that 2 fundus photographs of the patient or 3 visual fields of the patient or both will be read by the masked reading centers. And if they find any change and if the change is confirmed by the reading centers, this will be intimated to the committee. And the committee will actually contact with the treating clinicians and obtain the anterior segment and posterior segment finding of these patients, compile all of it together and send it to the endpoint committee. The endpoint committee will see all the disc findings and the visual field changes and also the anterior segment, posterior segment finding, and confirm whether this was this change which was noted in visual field or optic disc was due to POAG or not, and confirm whether it is a case of POAG. In this phase 3 study, they actually did not use OCT. OCT was done for these patients, but OCT was not taken into consideration for diagnosing POAG because phase 1 and phase 2 did not have OCT for its diagnostic criteria. So in this study, phase 3, OCT was done, but not used in the diagnostic criteria. So statistical analysis was done with Kaplan-Meier survival analysis. So they had looked at POAG conversion rate by 2 aspects. One, directly looking at the percentage of cohort which actually developed POAG without any adjustment. Next is they had looked at incidence with exposure time adjustment. So what is this exposure time adjustment? So this is a key concept which has been utilized in this study. So let us understand this better with an example. We can assume that a patient who was in the ocular hypertension treatment study had been undergoing treatment but has not developed glaucoma, but he was supposed to be followed up for 20 years. But unfortunately, the patient had died at 5th year of follow-up itself. So this does not mean that the patient has not developed POAG at all. If the patient had lived for another 15 years, he might have developed POAG at any point of time. So ruling out this patient that there is no risk of glaucoma is cannot be acceptable. So for this reason, they had used person years for calculating the incidence rather than using simply calculating how much patients have actually developed POAG. So this will help us to avoid underestimation of the lifetime risk, and this will also account for the unequal follow-up duration. Moving on to the results. So initial phase 1 study, out of the 1636 participants, the mean age at that time was 55.4 years and 25% of the patients were black population. So out of those 1636 participants, only 1121 patients were alive and 515 patients have actually passed away. So phase 3 study had 971 patients. So were these 971 patients the alive patients of 1121? Actually, no. Only out of the 1121 patients, 718 patients have participated in this phase 3 study, and rest were the 253 patients had actually passed away, but their records were available. So this has been utilized in this study. And the mean follow-up of this study was 20.2 years, and the mean age group of the phase 3 study was 73.8 years. And in the phase 3 study, it was 22.7%, which was the black population. The mean IOP was 18.4 with a vertical cup disc ratio mean value of 0.5 and a MD of minus 2.5 decibels and pattern standard deviation of 2.73 decibels, and a foveal sensitivity mean was noted around 30.8 decibels with a logmar visual acuity of 0.09. So what was the incidence of POAG in this group? The unadjusted POAG incidence was 29.3%. That is, 483 patients out of the total cohort had actually developed POAG. But adjusting for the exposure years, the incidence goes up to 45.6%. And the incidence among the black population was actually even higher, which was 55.2% compared to the other races, which was 42.7%. So out of these 29.5 unadjusted patients, the POAG with disc deterioration alone without visual field defect was noted in 12.1% of the patients, and with visual field defect without a disc change was noted in 4.7 patients. 12.5% of the patients had both disc changes as well as the visual field changes. And other forms of glaucoma was noted in 12 patients. 5 patients had PXF glaucoma, 3 patients had angle closure glaucoma, 3 patients had combined mechanism glaucoma, and 1 patient had pigmentary glaucoma. All these patients were not included in the incidence of POAG. Next, comparing the incidence between the observation group and the treatment group. Observation group had actually the incidence of 49.3%, which was slightly higher compared to the medication group, 41.9%. What we have to note here is the observation group had been under observation only for the first 5 years, and the medication group, this was followed only in the phase 1 trial. Right from phase 2, both the groups have been receiving treatment. And after the phase 2 has been over, the treatment protocol was not actually followed. So all the patients, both observation group patients and medication group patients, were actually treated or not treated based on the clinicians who were treating them, and it was left to their discretion. So protocol was not properly followed after 2009. So here we can see the two curves. There had been an initial gap starting, which at the 5 years, which is where the discrimination between the observation group and medication group was maintained. And after the 5th year, the curve is almost parallel between the two groups. And we can see after 15th year, the incidence of POAG had actually steeply gone up after 15 years, both in the observation group and in the medication group. So comparing the race and the incidence of POAG. Yes, the incidence is slightly higher in the black population compared to the other race, and the use of medication was also increased in the black population compared to the other races, and also any form of laser procedures or surgical intervention was more in the black population compared to the other races. But the authors have clearly stated that risk stratification is more important than considering the race alone as an individual risk factor. So the risk prediction model, as discussed earlier, as per the phase 1, they had actually used age, IOP, central corneal thickness, vertical cup disc ratio, and the visual field pattern standard deviation to categorize the patients into low risk, medium risk, and high risk patients who are at risk of developing POAG in the future. And in these categories, they had looked at the incidence of POAG at the 20th year follow-up. Here we can see low risk group had an incidence of 31.7%, medium risk 47.6%, and high risk patients had actually 60% chances of developing POAG, which is almost double as that of the low risk patients. And even in this, we can see after 15th year, there is a steep increase in the incidence of POAG. Comparing the visual field outcomes. Out of all the patients who had developed POAG and assessing all the patients, visual field loss had been noted in 25.2% of the patients only. And with the mean deviation worse than 22 decibel was noted in 3.2 patients, which is around 31 participants. And visual acuity worse than 20 by 200 was noted in only 1.2% of the patients. Considering the severity of the disease, which was noted among these ocular hypertension patients, most of the patients had early to moderate stage of the disease only in POAG. And when patients had both eyes, the worser eye with an advanced disease was noted in around 23% of the patients. So coming to the treatment burden. Again, to emphasize, treatment was actually continued or stopped after ocular hypertension phase 2 itself, and it was left to the clinician's discretion whether to treat that patient or not. Protocol was not followed after ocular hypertension phase 2 study. So when assessing all these patients, 72% of the patients were actually on medications, that is 696 patients. So out of these 696 patients, 304 patients developed POAG and 392 patients did not develop POAG. And 271 patients who did not receive medications, out of them, 68 patients developed POAG and 203 patients did not develop POAG. Coming to the procedures which was done, around 9.6% of the patients underwent laser trabeculoplasty and around 5.4% required laser iridotomy for narrow angles and 3.4% of the patients actually required filtering surgery and another 3.4% of the patients required cataract surgery and filtering surgery together and 16 eyes actually required tube surgery.
Can you go back to the previous slide, ma? I just
Yes,
have
sir.
a quick question. I know we have to discuss it at the end, but the
Yes,
table
sir.
where you have the developed POAG, did not develop POAG, and those on
Yes, sir.
medication, not on medication. Do you think we can derive any conclusion from this? Whether we can assess what kind of risk is there if you don't use the medication and things?
Sir, it is actually
Yeah.
there is 50-50 chances that if you use the medication, that the reduction in chances for POAG, but the severity is highly variable, sir.
Yeah. So why is it variable? Because these are selection bias, because these
Yes, sir.
patients are not on medication because they have a low risk already.
Yes, sir.
So from this table, we cannot say that medication, not using medication is actually beneficial. It looks like that, no? At a
Yes, sir.
glance. But unfortunately, we cannot use that, strategy because this is not an RCT. After
Yes, sir.
the second phase, they have not put on medications. This is
Yes,
just
sir.
for the sake of the audience who will probably be looking at this and coming to some conclusion. Continue.
Yes, sir. So, reviewing the literature, there had been only 2 studies which had followed up the ocular hypertension patients for 20 years, and the population is very less, which cannot be generalized. This study by Lundberg et al. Had studied 33 patients and followed up for 20 years, and they had reported an incidence of 33.3% of developing POAG, and the other study has also developed 25% of incidence of POAG in ocular hypertension. This actually matches with our unadjusted incidence, which is noted in this study. So the strengths of this study would include it has got a large sample which cannot be which matched at any other study so far, and it has gotten solid 20-year follow-up, and it has followed a rigorous endpoint confirmation, and they had carefully followed up and tried to trace as much as possible patients to include in this study. The limitation would be many patients had actually lost to follow up, and the death which is reported in this study is actually alarming because around 500 patients have actually died, and the reported cases are also around 500 of POAG. So we exactly would not be able to come to a conclusion whether the incidence of POAG unadjusted can be trusted or not. And this had actually been a non-randomized treatment after phase 2, which is an important drawback, and they have not used OCT parameters in phase 3 into diagnosing the patients. So the take-home message from this study would be the lifetime POAG risk adjusted for exposure time would be around 46%, but only 25% of the patients would develop an visual field loss. And they have emphasized that risk-based treatment is important in all of the ocular hypertension treatment patients. So we'd like to discuss on whether which cases to be treated, and from this study, what will be our conclusion in treating which patients. And we have to decide whether this study has over predicted or under predicted the incidence, and whether OCT could have been used as an endpoint diagnosis, and also whether this study can be applied to Indian population or not. Thank you, sir.
Thank you, Aishwarya. Can you keep the slides in the last slide which you had on the questions?
Yes, sir.
So we have, including Dr. Manisha, we have two people in the panel now. Dr. Deven Tuli is here. So I would ask Dr. Deven first to give his opinion on the study per se and its biases. And of course, these questions which have been put up, if you have your opinion on these, please. Dr. Deven. Yeah, I think he's not able to connect or what. Maybe I'll ask Dr. Manish, please, your take on this.
So definitely, I would congratulate Dr. Ishwarya for making a very crisp presentation and putting all the findings of the study quite clearly for everyone to understand, and pointing out the limitations also, which are important. So as of now, actually, this study is very valuable to us because it shows us that, of course, if you see the even the patients who have actually developed glaucoma at the end of 20 years, if you see their mean deviations and all, they are quite low. So the severity of glaucoma is not very bad in the this cohort of patients. So the one of the messages which we are following today in clinical practice is that when we find patients who fit into the same category as in this study, we treat only if there is high risk or there is a significant risk. And low risk patients we are not putting on treatment. However, we are continuing to monitor. Second point is that if there is a delay in treatment also, if the patients develop glaucoma a little later, we are seeing that it is not impacting the final outcomes or the progression rates in the long term. 20 years is quite a long term. So by observation, definitely we are not losing anything, and we should continue our practice as we are following to treat only patients who are at a higher risk. Now, coming to the second category, second question about whether OCT, definitely now, when this study was started, I think we had only the time domain OCTs, so they were quite basic. But now we are following with the more advanced OCTs, and definitely the ganglion cell layer study is very important in this group of patients, and I would say that that could change the whole picture if if that is introduced into this study, but unfortunately it can't be introduced. But I think if it does have a potential to change the picture. So today when we are following patients who are especially not on treatment, observation of the ganglion cell layer would be a very, very important addition, which is not covered in this study. So that's the basic comment. And whether it is applicable to the Indian population, I think that India today, most of the centers in India do not have the kind of robust backing and finances to do such a study. And I don't know whether we'll be able to generate such data. So I think it is applicable to follow. But being very important point, which is for people in practice, is not to miss angle closure as ocular hypertension. That would be a very grave error because progression rates in angle closure are way higher than open angle. And trying to say that okay, your pressure is 24, but you are a hypertension patient, he may be going home and getting a spike of 30 or 40, you don't know. So angle closure is very important to look at the angle carefully before you label anybody as just a hypertensive. Thank you. Dr. Bhaskaran, you can.
That is very well put, Dr. Manish, because in our context, angle closures are important. We do see that patients are treated as ocular hypertensives and they have PAS when they come because gonioscopy was not done as a routine. Because especially when you have a borderline angle closure and the patient was told ocular hypertension, they tend to develop this PAS and then this fluctuation in the IOP worsens it. Not just that, glaucoma is a disease of risk factors. That is something which we have to keep in mind. Apart from the ocular hypertension risk factors, if there is a family history which was not coming in the initial study, but I think that is also very important. Nowadays, we do see a lot of patients coming with it. And the severity of glaucoma in the family members also counts. And also, we need to use the risk factors listed out in the ocular hypertension treatment study. That is very important. As far as the OCT based endpoints is concerned, as you can see that even in this study with 20 years of follow-up, we are getting patients with higher visual field loss in a very small group of patients. Of course, there is a list of treatment that was given subsequently for those high risk patients. If you meticulously follow them up, we should be able to get reasonable outcomes at the end, even without the OCT being taken into account. That is what is shown. But for those high risk patients, I think it is better to follow them up with the OCT based endpoints so that we can treat them aggressively to not lose their vision subsequently. So that way, I think OCT is something which becomes a part and parcel of our follow-up of early glaucomas and ocular hypertension patients, especially those with high risk, I would say. I wouldn't probably, tax the system as well as the patient's pocket for every ocular hypertensive that comes in. But I think at least for the high risk patients, we should be able to do it. And obviously applicability to Indian population, if you see the risk factors are all applicable in our routine practice itself. And I think, we should probably try to, initiate such follow-ups. We are all, I think, connected well. I'm sure we should be able to pull up something like this. If, GSI or, one of the institutes starts to, do such kind of work. Cohort studies are very important, if not RCTs. RCTs are very expensive, but this is something which can be done. And I would say that there are certain biases in this study. For the sake of audience who are listening, if a research methodology part of it, you should actually look at the attrition bias, which is the patients not there or who have passed away. But I wouldn't take that as something which is an exclusivity. This patients who are deceased, because I think that is a reality. We are actually in glaucoma always keep the life expectancy of the patient, and the endpoint as death actually kind of puts it that okay, this patient till their life end they have been enjoying good vision. So I think the person years conversion gives you the adjustment for that. And if you are over predicting or under predicting the incidence, I would actually say that it is a bit of an over prediction only, because we are not looking at the visual field loss alone, the functional loss alone. So in terms of conversion in terms of the optic disc findings, alone, if you are taking it, definitely we are over predicting it. If we actually take it, in the first phase, the number needed to treat became almost 40. Usually, if it is less than 10 only, it makes sense to treat. But I think that is something which we have to keep in mind. There is definitely some over prediction in these kind of studies. But again, we will emphasize that if there is a high risk ocular hypertensive, we should be aggressively treating. And I think with the introduction of SLT as the first line treatment, many people can actually benefit by that when you have an high risk. So those are factors which are not included in this study, but I think that is practically very useful. I always treat my high risk ocular hypertensives, advise them to go with the laser trabeculoplasty, but I don't take them off medications if they are able to tolerate the medication. At least one medication like a prostaglandin analog is used. I'm only talking about the high risk. The low risk and the moderate risk, depending upon various situations, we can handle it. If they are not coming for regular follow-up, I treat a bit more aggressively. Otherwise, I think with careful follow-up should be fine. I think that's my take on this. And I again congratulate Aishwarya on presenting it very nicely and crisply. But I would also advise that you always use the 95% confidence intervals when you are putting the main
Yes.
points around the mean, because that
Yes,
will
sir.
give you what is the low end and what is the high end. That will give us,
Okay, sir.
okay, in different populations it can be different. So if you have a
Yes, sir.
high risk population like the black, we take the higher end of the confidence interval, so to
Okay,
be on
sir.
the safer side, because generalization happens only when you are using confidence intervals, not the mean alone. Okay, so
Okay,
that
sir.
is a good practice to actually put the confidence intervals.
Okay, sir. Sure, sir.
Yeah. Any other points, Dr. Manish, if you want to add?
Actually,
Probably.
one other point which is of clinical importance also in the risk factors is the occurrence of pseudo exfoliation. So, because we know that pseudo exfoliation in other studies have shown to have much higher fluctuations and definitely a higher progression rate than standard open angle glaucoma. And that is also one of the risk factors which has not been looked at in this cohort. So it is an important extra point, I would say.
Yeah, so that's why we think about risk factors. So always look at the other factors, like if the patient is an asthmatic using steroid inhalers, this ocular hypertensives may turn out to be a steroid responder also. So you need to keep those things in mind. One point in ocular hypertensives is if you are not treating and the patient has a very small disc, so that can be a disc at risk when you have a higher intraocular pressure. So that is something which you have to be very careful. And corneal thickness is only an indicator, and if there are other risk factors, it is better to treat. Sometimes even with the corneal thickness being high, the patient's conversions happen. So when we are getting more aggressive with the thin corneal thickness, with the higher corneal thickness, we cannot be too complacent also. So that is something which we have to keep in mind. So that's the final thing. Always look at the risk factor, the risk factors that are shown in the OHT study, and probably look at the angle, gonioscopy. That is very, very important. So those are three take-home messages I think we would emphasize on. Yeah.
Yes.
Yes. I think because we don't have any talk today,
Yeah.
so we are finishing faster. So
Yes. Yes.
if we don't have any more points, I think we will probably call it a day, because I think after some time we have started, and it's a very nice study that Dr. Aishwarya has presented.
Yes.
Yeah.
So thank you very much, Dr. Aishwarya, for your brilliant presentation and the point you have raised. And Dr. Bhaskaran, as usual, you have really thrown a lot of light on not only the study itself, but the methodology involved and the logic behind everything. And thank you very much for your time and inputs. Thank you and good night, everybody.
Thanks a lot. Good night.
Thank you, sir.
Yeah, Sai, I think we can close the live stream. Aishwarya, you can probably convey to Dr. Satyan that we ended well. Okay. So hopefully we should be able to get more in the future. Thank you. Thanks a lot,
Yes,
Sai.
sir. Thank you so much, sir.